Live from Boston, my name is Emilio Madrigal, and welcome to this edition of pathCast. Today, I am honored to bring back, I should say, a dermatopathology lecture. And believe it or not, it's been 3 years since we moved over from or joined Facebook after being on YouTube for a while. And since that time, about 3 years ago, we haven't had a DERMPATH lecture. So I'm delighted to welcome Rosalind Nazarian, who is one of my colleagues here at Massachusetts General Hospital, where she is an associate professor at Harvard Medical School. And coincidentally, today she's celebrating 15 years of service at Mass General. Today, Dr. Nazarian is going to be presenting a DERMPATH lecture, like I mentioned, and the title is Vasculitis and Vasculopathy, a Case-Based Approach. She'll be using a combination of PowerPoint and scanned digital images, and hopefully you had a chance to review those. And as always, please, if you have any questions, go ahead and post them on the YouTube and Facebook chat windows, and I'll make sure to pass those over to Dr. Nazarian. So with that, I will now turn the microphone over to Dr. Nazarian.
Hello, everybody. Thank you for that introduction and for the invitation to speak today in this wonderful forum hosted by pathCast. Today's topic is on vasculitis and vasculopathy, a case-based approach. I'm speaking to you from Boston. I'm Rosalind Nazarian from Mass General Hospital, academic dermatopathologist. I have no financial disclosures, and I'm excited to share the selection of cases with you today that highlight really the clinical and pathological correlates in dermatopathology, and this discussion is truly relevant to both clinical and anatomic pathology, reflective of my training and my interest. So the learning objectives for the lecture today are to differentiate purpura due to vasculopathy and vasculitis, to describe histopathologic features of small superficial and medium-sized deep vessel vasculitides, as well as their classification schemes over time, and to perform clinical pathologic correlations using a combination of ancillary laboratory studies, immunofluorescence, and serology. And for that, we'll be taking a case-based approach. Let's begin by defining the terminology. Purpura in Latin means purple, and it describes the discolorations on the skin that don't blanch upon applying pressure. And there are two main forms of vascular injury. Of course, there's vasculitis, wherein the inflammation is directed towards the vessel wall, resulting in endothelial cell damage, fibrinoid necrosis, and erythrocyte extravasation. As well, there's vasculopathy, characterized by an intravascular thrombosis, which can actually be seen in a number of inflammatory conditions. The key to diagnostic certainty among vasculitis and vasculopathy is really to consider whether the process is primary or secondary, the size of the involved vessel, the inflammatory infiltrate, and any ancillary studies, as I'll be describing. But most importantly, clinical correlation is required. Let's take a closer look at primary versus secondary vascular injury. A true primary vascular process is where the inflammation is centered about the vessels and extends beyond the area of ulceration that can result from tissue ischemia. In contrast, a secondary vascular injury is just incipient vessel wall involvement in the setting of an exuberant surrounding inflammatory process. We commonly see this in the setting of arthropod bite reactions, and especially proximity to ulcer bed. And it can also be secondary to underlying diseases, particularly connective tissue disorders. Let's take a case look at this sample case. So let's decide, is this primary or secondary vascular injury? Let's take a closer look of this area here. Now, what you'll see is that there are neutrophilic inflammation. It's directed towards the vessel wall. There appears to be a hint of leukocytoclasia, and certainly we see erythrocyte extravasation. So is this a primary vasculitis? It turns out that this is a high-power focus of a case of Sweet syndrome. I'm going to back up now just to show you. If you see the papillary dermal edema, that's truly characteristic of this neutrophilic dermatosis. And truly, there is a dense, diffuse neutrophilic infiltrate spanning the entire superficial and deep dermis in this process. Let's try another case. Primary or secondary? Is this a thrombotic vasculopathy? Is that a focus of acute vasculitis? These are foci from a case of calciphylaxis. This diagnosis can never be made based on histopathology alone, but truly requires a clinical correlation. As you see in the image on the top right, there's concentric calcification involving a medium-sized vessel within the panniculus. And in the bottom left, you see that the von Casa stain additionally highlights extravascular calcium involving septi within the subcutis. Sometimes the clinical picture is enough and cases are not biopsied. There are three main types of clinical purpura, and they result from the underlying mechanism. For example, vascular occlusion imparts a retiform or net-like clinical appearance. Simple hemorrhage is flat purpura, and the one we most commonly discuss is ANCA-related or immune complex deposition of palpable purpura. Of course, purpura is a common, non-specific medical sign, and our patients present with complex disorders, most often with a number of morbidities. Therefore, the skin biopsy remains the gold standard for the diagnosis of cutaneous vasculitis. Let's take a moment to remind ourselves about the vascular bed in the skin biopsy. The capillaries affected by small vessel vasculitis are present in the superficial dermis, and medium-sized vessel vasculitis truly affects muscular arteries in the subcutis, most especially at the dermal subcutaneous junction. Therefore, an adequate skin biopsy of an established lesion is needed. This image by Carlson et al. Aptly demonstrates that phenomenon. If you take a look at the top left, a shaved biopsy is not able to differentiate between leukocytoclastic vasculitis and a process of micropolyangiitis. However, even a punch biopsy might entirely miss a case of polyarteritis nodosa, so truly a deep incisional biopsy is required. Based on this schema, it seems reasonable to classify vasculitis based on the vessel size. So small vessel vasculitides we recognize as lupus vasculitis, Henoch-Schönlein purpura, hypersensitivity vasculitis, and medium-sized vessel vasculitides include eosinophilic granulomatosis with polyangiitis, microscopic polyangiitis, and so forth. Of course, many classification schemes have been proposed over time, beginning with one of the earliest ones in 1990 by the American College of Rheumatology. They set forth criteria for the classification of vasculitis based on immune complex presence, ANCAs, their histopathologic pattern, and importantly, the organ distribution and vessel size. The problem is there was a lack of dermatology input, and sensitivity and specificity suffered as a result. 4 years later, a consensus conference on vasculitis nomenclature was held in Chapel Hill, North Carolina, and definitions were created for 10 forms of vasculitis. Again, the role of ANCA played a major part in this classification scheme, as well as organ distribution and vessel size. This is an image that may be very familiar to many of you, and I think of it as a good image for describing the size of vessel involved in the various vasculitic syndromes. However, it phenotypically lumped certain disorders that shouldn't be lumped as such. Polyarteritis nodosa, a cutaneous nodular vasculitis, is now lumped as a medium-sized vessel vasculitis with Kawasaki's disease, which is a mucocutaneous coronary artery vasculitis. So the main problem is truly a pigeonhole phenomenon, and I hope the series of cases that I describe will show you that clinical, laboratory, and histopathological criteria in combination offers the best approach. Let's take a look at the first scan slide. The patient is a middle-aged woman with Waldenstrom macroglobulinemia who presented with levator reticularis. Her skin biopsy shown here. At low power, there don't appear to be any significant alterations. Zooming in at higher power, the epidermis appears relatively normal. And in the superficial dermis, there appear to be distended capillaries containing erythrocytes wherein the borders are no longer discrete. So it's not simply vascular congestion. Larger vessels don't seem to be involved. The dermis appears uninvolved, and most notably, there's no inflammation to speak of. The eccrine glands are unperturbed. There's no sign of ischemia here. And so this slide represents a case of thrombotic vasculopathy. In the setting of the clinical history I provided, this was due to a type 1 cryoglobulinemia, which often associates with hematological disorders. Let's take a look at some other examples of thrombotic vasculopathy, beginning with this case here. The patient was an elderly female, and she had no significant past dermatological history. She developed painful purple feet and toes bilaterally, as shown in the image below, and no perfusion abnormalities were detected by our vascular service. The clinical concern was for cryoglobulinemia, an embolic etiology, or a connective tissue disease. The skin biopsy shows acral skin, as noted by the stratum corneum here. And again, significant lack of inflammation, and I draw your attention to the foci highlighted by the arrows. At this power, there seems to be thickening of the wall of the vessels. But upon closer magnification, one notes that there's actually been recanalization of the vessels by a process that's actively thrombosing. And there's a unique quality to these more developed thrombi as shown here. They have a waxy, cracked appearance. Notably, there's no inflammation surrounding these involved vessels. A PASD stain highlighted the thrombi as shown here, and in addition showed a bonus diagnosis of superficial fungal infection with hyphae seen in the stratum corneum. Laboratory studies later showed trace amounts of kappa-Bence-Jones proteins, but remarkably, the patient had a high cryocrit at 14%. If you recall, the cryoglobulins are assayed by patient serum having incubated at 4 degrees Celsius for up to 72 hours. The test tube is then agitated, and when a flocculent appearance is seen, such as a snow globe appearance, that confirms cryoglobulin. That serum is then assayed for immunoglobulins using gel electrophoresis to specify. In contrast, when a thready or potato chip-like appearance appears, we know that to be fibrin. Remember that cryoglobulinemia is actually composed of 3 types, and only type 1 cryoglobulinemia is thrombotic in nature. This is the one that's associated with hematological malignancies. It's called monoclonal cryoglobulinemia. And the reason, in large part, is because these are predominantly from IgM, and IgM is a pentameric protein. So it's truly like an entangulation of these large protein in the blood. In contrast, types 2 and 3 cryoglobulinemia impart a picture of acute vasculitis, and they're associated with a number of other underlying disorders, including hepatitis and autoimmune diseases. Here's a summary of thrombotic vasculopathy. Notably, non-inflammatory hyaline thrombi are seen. And just to wrap up case 1, a case of monoclonal cryoglobulinemia. Indeed, the patient had subsequent workup that revealed multiple myeloma, and following treatment of her myeloma with Rituxan, Velcade, and Decadron, all clinical skin lesions resolved. Let's take a look at another case of thrombotic vasculopathy. This artwork is by Ivan Ivazovsky. The patient is an elderly male whose status post 3-vessel cabbage and aortic valve replacement. He complained of fatigue and chest discomfort. Admission medications included aspirin and warfarin for his mechanical aortic valve. A diagnostic cardiac catheterization procedure was performed and revealed aortic insufficiency with valvular leak and critical stenosis of the left circumflex. He underwent an emergent redo coronary artery bypass graft and valve reconstruction, and this was all on hospital day 1. By hospital day 10, the patient's left lower extremity was cool and dusky with only faint pulses by Doppler, which had previously been 2+. Both lower extremities showed skin mottling and petechiae, which was new. By hospital day 12, he'd had new onset painful purpuric lesions involving arms, hands, legs, and feet bilaterally, and dermatology was consulted. The skin biopsy of a left lower extremity was performed for a clinical question of DIC or vasculitis. And what the skin biopsy showed was, again, non-inflammatory intravascular thrombosis, shown here involving vessels in the superficial dermis. In other areas, there was coagulative necrosis of the epidermis, shown here. Again, the thrombi persisted, and as well, fibrinoid necrosis of the vessel walls was present without an accompanying inflammatory infiltrate and extensive erythrocyte extravasation. But even away from these epidermal changes in the deeper dermis, vessels again were thrombosed. Indeed, large medium-sized vessels were thrombosed without any accompanying inflammation. So a thrombotic vasculopathy was diagnosed by skin biopsy. The warfarin was discontinued and he was treated with IV heparin. Now, by hospital day 10, the patient had a new arterial clot and a 63% decline in platelet counts. This leads anything above 50% should lead to the suspicion of HIT, heparin-induced thrombocytopenia. In fact, heparin was discontinued and he was begun on argatroban, a direct thrombin inhibitor. We performed testing for heparin platelet factor 4 antibodies, but these were negative on 2 separate occasions. Unfortunately, the remainder of the patient's hospital course was complicated by severe GI hemorrhage, aspiration pneumonia, acute renal insufficiency, and he expired on hospital day 33. The diagnosis in this case is warfarin skin necrosis. In fact, thrombosis that occurs paradoxically as a complication of antithrombotic therapy is an infrequent but significant source of treatment-associated morbidity and mortality. Warfarin does not only induce cutaneous skin necrosis, but also can be associated with cholesterol microembolization and other adverse effects shown here. The pathophysiology of warfarin skin necrosis is actually a transient imbalance between the procoagulant and anticoagulant pathways that's due to the more rapid decline in vitamin K dependent clotting factors that are specifically inhibited by warfarin, including factors 2, 7, 9, and 10 in comparison to protein C and S levels. Histologic mimics of warfarin skin necrosis include heparin-induced thrombosis, disseminated intravascular coagulation, and an array of inherited procoagulant states. Clinical clues are essential. For example, in DIC, patients have multi-site fibrinolytic hemorrhage, including at venipuncture sites. Peripheral blood schistocytes can be seen. Inherited protein C or S deficiency. is difficult to differentiate from warfarin skin necrosis, but interestingly, warfarin necrosis typically occurs at sites of increased subcutaneous fat, in contrast to heparin-induced thrombosis, where lesions occur at the site of injection. As I mentioned earlier, heparin platelet factor 4 antibodies are very helpful in combination with an over 50% reduction in platelets for the diagnosis of heparin thrombocytopenia. Warfarin skin necrosis typically occurs 3 to 6 days following the initiation of therapy, but was a bit later in this case. The treatment of warfarin skin necrosis is predominantly supportive with fresh frozen plasma and vitamin K that's aimed at restoring levels of protein C. Monoclonal antibodies are costly and they're not routinely available, and the use of a heparin and any other anticoagulant is highly recommended. Of course, as it's non-inflammatory, treatment with steroids has not been shown to alter the course of disease. To wrap up this case of warfarin skin necrosis, we saw thrombotic vasculopathy. Lesions involved fatty areas of the skin, including the thighs. Patient had low D-dimer levels, which would have been elevated in a case of disseminated intravascular coagulation, and negative heparin platelet factor 4 antibodies, excluding heparin-induced thrombocytopenia. This is an immediate indication for drug cessation, so the patient should be taken off warfarin and another class of anticoagulants should be used. To date, there have not been any reports of heparin-induced skin necrosis in the patients that were treated for warfarin skin necrosis. Let's take a look at another digital slide. This patient is a 36-year-old woman who presented with palpable purpura involving her bilateral lower extremities. Her skin biopsy demonstrates an inflammatory infiltrate predominantly affecting the superficial dermis. As you can see, the deep dermis is uninvolved. The epidermis appears unaltered. Looking a little closer, we can see that the inflammatory infiltrate is composed predominantly of neutrophils. You'll notice the extensive erythrocyte extravasation. And looking a little closely at this vessel here, there's been fibrinoid necrosis. This triad is characteristic of leukocytoclastic vasculitis. So that is the pathology diagnosis in this case. And now let's take a look at another few cases of an acute vasculitis. Beginning with case 3 here. The patient was a 79-year-old male in his usual state of health until 2.5 months prior to presentation to his rheumatologist. And he complained of painful joint swelling in the hands, ocular erythema shown here, and a rash comprised of purpuric macules on the lower extremities as shown on the bottom right. The clinical differential included urticaria, Henoch-Schönlein purpura, lupus, and vasculitis, and a skin biopsy was performed. The histology looked very much like the case on the digital slide that I just showed you. You can see in this inset that the medium-sized vessels were uninvolved. So this is a superficial small vessel vasculitis, again involved by neutrophils. At higher power, you can see in this large oval leukocytoclasia, which is the nuclear debris of neutrophils. And in this circle shown here, fibrinoid necrosis of the vessel wall with erythrocyte extravasation highlighted here. Leukocytoclastic vasculitis is not a disease entity unto itself, but rather a reaction pattern that's due to a number of underlying disorders. So the differential is quite broad. And most often it's idiopathic, but we can determine cases where it's immunologic. For example, Henoch-Schönlein purpura using immunofluorescence. Infectious etiologies are very important to exclude, particularly in the setting of a neutrophilic dermatitis. Special stains and cultures are recommended. Drug-related etiologies should be sought as well as serologic studies for anti-neutrophil cytoplasmic antibodies. Just a sidebar here about drug-induced vasculitis. Typically, though not always, there's a higher level of eosinophilic infiltrate as compared to non-drug-induced leukocytoclastic vasculitis. The array of etiologic drugs is quite broad. I'm a huge proponent for direct immunofluorescence. I find it to be essential for narrowing the differential in a large number of cases, and I encourage our inpatient dermatologists to always obtain a second biopsy for performing direct immunofluorescence. The timing and location of that biopsy is critical. Ideally, you want a proximal lesion of 8 to 24 hours of age. And characteristically, we find immunoglobulin deposition around the vessel wall, and I'll talk about some cases where basement membrane zone positivity, in addition to the vessel wall immunoreactivity, can be quite helpful. So going back to this patient, 2 months after his initial consultation, a second biopsy was obtained for direct immunofluorescence. His immunofluorescence showed immunoreactivity for IgG around the vessel wall as shown here, but in addition along the basement membrane zone in a granular, not linear pattern. There was immunoreactivity also for C3 and IgA. In addition, his serum complement levels were quite reduced. So he had hypocomplementemia, he had a leukocytoclastic vasculitis, and in addition, he had the dual basement membrane zone and perivascular immunoreactivity by immunofluorescence. Taking all of these into consideration, the diagnosis of this case was hypocomplementemic urticarial vasculitis. Anti-C1q antibodies are a helpful marker of this disease. There does seem to be some overlap with lupus vasculitis, but in this patient, anti-dsDNA and anti-Smith antibodies were negative. Mixed cryoglobulinemia types 2 and 3, as I mentioned earlier, can also impart a small vessel vasculitis, and as we discussed, drug-related etiologies and hypersensitivity vasculitis, as well as Henoch-Schönlein purpura, which is characterized by IgA deposition in direct immunofluorescence. So this was a case of hypocomplementemic urticarial vasculitis, and honestly, the direct immunofluorescence in this case was essential for confirming this diagnosis. And it's important to make this diagnosis because these cases are more difficult to treat. So I discussed about the timing of the immunofluorescence, and just a side note about the distal extremities in elderly patients due to the presence of stasis dermatitis so ubiquitously in the population, there can be non-specific staining, so proximal biopsy is preferred. Here's a flow diagram to show the pattern of immunofluorescence and the diagnosis that you can achieve. Case 4. This is a sad case of a 24-year-old pregnant woman who was admitted with a history of hepatitis C virus and recent intravenous drug abuse, and she was admitted for methicillin-resistant Staph aureus bacteremia. Shortly after admission, she delivered a preterm infant girl. 3 days later, she developed acute kidney injury, abdominal pain, scattered erythematous, non-blanching papules and plaques on the lower extremities as shown here. Her skin biopsy showed, again, leukocytoclastic vasculitis, characterized by that triad of erythrocyte extravasation, fibrinoid necrosis of vessel walls, and a leukocytoclastic neutrophilic infiltrate. Here's a higher power. Direct immunofluorescence in this case showed immunoreactivity for IgA surrounding the vessel walls alone. She was diagnosed with leukocytoclastic vasculitis. Again, as I mentioned, we looked at patients with a history of IBDU We found 10 cases within a 14-year period. Of course, this is a difficult history to elicit and to be confident about. Patients all had negative wound cultures and special stain. They were aged 39.7 years on average. 5 were male and 7 had hepatitis C. Of interest too, the cases in our LCV series both showed Henoch-Schönlein purpura, and this patient was one of them. It's important to note that there's other vascular manifestations of substance abuse, so we could have easily seen a hypersensitivity vasculitis, urticarial vasculitis, Churg-Strauss syndrome, now known as eosinophilic granulomatosis with polyangiitis, and so forth. Indeed, subcutaneous cocaine injections have a direct vascular cytotoxic effect in rats in some studies. So the diagnosis in this case was Henoch-Schönlein purpura. She had had many factors for development of this disorder, including hepatitis C virus, recent intravenous drug use, streptococcal bacteremia, and of course, again, immunofluorescence was quite helpful in determining the diagnosis. Case 5. This is a patient who's 68 years old, male, with long-standing glomerulonephritis on hemodialysis. He had type 2 diabetes and a recent deep venous thrombosis. He presented with painful angulated ulcers with these violaceous, irregular borders involving the bilateral legs. The skin biopsy showed extensive epidermal, dermal, and subcutaneous necrosis. I draw your attention to the area shown here. At high power, we saw branching septate fungal forms. In the deeper panniculus, there were calcium deposits, coarse ones circumferentially involving vessels, but also extravascular calcium deposition within the interstitium. In other areas, there appeared to be a medial calcium deposition with fibrointimal hyperplasia of the vessel wall. Is this Mankeberg sclerosis, a common incidental finding? However, in other foci, we found finely stippled calcium involving capillaries in between adipocytes as well as the adipocyte wall. In the correct clinical context, as was seen in this case, in painful angulated ulceration, the diagnosis of calciphylaxis was made. This is a rare disease with high morbidity and mortality that's usually due to sepsis, as we saw this patient had superinfection with the fungus. There's no consistently effective treatment, and this patient had every risk factor for the development of calciphylaxis listed here except female gender. He had chronic kidney disease, he was on hemodialysis, he was diabetic, obesity, he was even taking warfarin. And interestingly, statins have been shown in some studies to have a protective effect, and that's the only medication that's been shown to do so. Going back to this patient, his clinical lesions continue to progress. Of course, he had the superinfection with Aspergillus. He was transferred to the intensive care unit after experiencing pulseless electrical activity and sadly passed away following a second episode of cardiac arrest. So to wrap up case 5, this is a case of calciphylaxis, also known as calcific uremic arteriolopathy. Of course, we now recognize that this occurs in patients who are indeed non-uremic. And in fact, in some cases where the histopathology may be more subtle, the use of histochemical stains for calcium, such as the von Casa, which we use here in this hospital, but also alizarin red, can be quite helpful. And in addition, in cases where the subcutis is not present on the biopsy, the finding of perieccrine calcium deposition can be very helpful towards making the diagnosis in the correct clinical context. Just to throw back to the case I showed you earlier in this discussion. Okay, let's take a look at the third scan slide. This patient was a 56-year-old male who presented with tender subcutaneous nodules on the lower extremities. Taking a look at the skin biopsy, my first thought is, wow, this is an excellent biopsy. There's not been significant crush artifact from the forceps. The punch extends to involve a good portion of the subcutis. The tissue is viable, has been fixed appropriately. You can see the epidermis shows no alteration. The superficial dermis shows no significant findings. And the area of interest is truly here. And here's a great focus. So you can see that there's involvement of a vessel here. The lobules in the subcutis appear not to be significantly inflamed, but rather the inflammation is concentrated around this medium-sized vessel, as you can see here. Extensive infiltration of the vessel wall. So this is a medium-sized vessel vasculitis. Is it Wagner's or granulomatosis with polyangiitis? I don't see granulomas here. And in addition, the lobules are not significantly inflamed. Could it be microscopic polyangiitis? I don't see involvement of the superficial small vessels. So our favorite diagnosis in this case might be polyarteritis nodosa. And as a secondary step, we'd confirm by showing absence of ANCA positivity by serology. So that was the diagnosis in this case. And now I'd like to discuss some other cases of medium-sized vessel vasculitis with you here. Our next patient is a 56-year-old male with Crohn's disease who presented with multiple erythematous tender subcutaneous nodules on the lower extremities. This is in fact the correlate to the histopathology I just reviewed with you. The dermatologist's clinical differential was for cutaneous Crohn's, which can either be granulomatous or neutrophilic, polyarteritis nodosa, which we now know that it was, and erythema nodosum, which this clinical appearance is actually quite reasonable for. As we saw that there was a lack of superficial dermal inflammation, and the inflammation was concentrated about this deep dermal vessel. The vessel was situated just at that junction between the dermis and the subcutis. Here at higher power, you can see infiltration in the vessel wall and absence of involvement of the superficial vessels. So this is polyarteritis nodosa. Cutaneous PAN is of course limited to the skin, may follow a chronic relapsing course, and importantly, only less than 1% of cutaneous PAN has been reported to progress to a systemic disorder. However, classic polyarteritis nodosa is a true systemic disease. It involves the kidneys, resulting in hypertension. Neuropathy may be seen. In fact, the renal involvement is the leading cause of morbidity and mortality in this population, and up to a quarter of these patients will have secondary cutaneous involvement. The etiology is unknown, but there have been associations with Crohn's disease, as we saw in this patient, but also hepatitis and streptococcal infection. When we see a medium-sized vessel vasculitis, as we exercised with the case I showed you, we talk about the nature of the infiltrate. We did not see granulomas in this case, but had we seen granulomas with giant cells, we might think of granulomatous polyangiitis or Wagner's. With presence of eosinophils and clinically asthma, we might have considered eosinophilic granulomatosis with polyangiitis. And of course, the renal vessel involvement may have led to a consideration of microscopic polyangiitis, but in this case, we made the diagnosis of cutaneous polyarteritis nodosa. Just a quick note about how ANCAs can be helpful in further differentiating between these entities. Cytoplasmic ANCAs, as shown in the image on top, are proteinase 3 related and often seen in Wagner's or GPA, and the perinuclear ANCAs are myeloperoxidase related and can be seen in Churg-Strauss or EGPA and microscopic polyangiitis. Of course, there are other target antigens, and up to 5% of the normal population can have positive ANCA testing. Case 7. This is our final case. It's a 46-year-old woman with a history of depression, substance abuse, and hepatitis C. She presented with a 3-week history of extensive retiform purpura involving the lower extremities with cutaneous necrosis, as shown here. Serology showed a positive P-ANCA with a high titer of 1 to 640. Of course, anything over 1 to 40 is already positive. She also had positive anti-cardiolipin IgM. ANA was negative, however, as well as rheumatoid factor and double-stranded DNA. Cryoglobulins were negative. She had a normal coagulation panel, and a CBC with differential showed a reduced number of neutrophils at 19%. Her urine was positive for tricyclic antidepressants as she was being treated, but her tox screen was also positive for cocaine and opioids. Here's her skin biopsy here. And what you'll notice at this power is that there's been a recent fibrin thrombus involving this vessel. But in deeper dermal vessels, there appears to be more vessel occlusion with a surrounding mixed inflammatory infiltrate. This mixed picture of an acute on chronic process is a hint for the recently emerged diagnosis of levamisole-induced vasculopathy. It's a clinical syndrome characterized by fever, neutropenia, as we saw in this patient, and retiform purpuric involvement with, in fact, a predilection for the ears. So that's a clue to this diagnosis, if you will. And it occurs following the use of levamisole adulterated cocaine by any means. And frequently reported lab values are the presence of the ANCA. You can also see anti-lupus coagulant antibodies. So the histology is that of a thrombotic vasculopathy and shows a mixed pattern, often with a concomitant leukocytoclastic vasculitis and tissue necrosis. All the skin lesions are known to resolve with cessation of use of the adulterated cocaine. Just a brief note about levamisole. It's actually an anti-helminthic agent that was used by veterinarians in the US that for many years was used as an immunomodulatory drug for rheumatoid arthritis. By 2003, its first misuse as an agent to cut cocaine was first detected. And even 6 years later, it was detected in 70% of seized cocaine that entered the United States. A clue to this diagnosis is anti-HNE antibodies. While these are nonspecific, it can certainly help between mimickers, which can include cryoglobulinemic vasculitis, which may also show a mixed pattern of thrombosis and inflammation, as well as Wegener's and Church-Strauss. The clue is to have a positive indirect immunofluorescence, and again, immunoassay techniques are very helpful. Toxicology screen, just a few notes that this has to be performed within 48 hours of last drug use. Levamisole has a very short half-life of 5.6 hours, and patients may often mask cocaine in urine samples using Drano or a bleach, and that alters the pH of the urine. So the best bet is to detect benzoyl ecgonine, which is the metabolite of cocaine, which can appear in the urine up to 60 hours even after a single use. I hope you enjoy this set of cases. To summarize this discussion, the histopathologic examination can make the distinction between vasculitis and vasculopathy. Awareness and recognition of the entities in differential diagnosis and the potential for systemic involvement is critically related to underlying drug etiologies, immunologic disorders, and so forth. Clinical pathologic correlation, I hope I've demonstrated that truly facilitates greater precision and accuracy in the final diagnosis. And of course, laboratory values can help. And the ones I've highlighted here today are cryocrit, NCAS, the D-dimer, a coagulation panel, and complement levels, as well as direct immunofluorescence. As a guide to your own laboratory evaluation, in the patient who presents with purpura in which a skin biopsy is performed, the first determination is between a primary vasculitis and a thrombotic vasculopathy. If small vessels are involved, I've listed here the diagnostic possibilities and the tests that are most helpful for discriminating among them. If a medium-sized vessel is involved, here is this list of diagnostic possibilities, and NCAS, CBC with diff, and urinalysis are the best next tests. In patients presenting with a true post-inflammatory thrombotic vasculopathy, the differential is short. These are the critical lab values to differentiate amongst them. And of course, in the setting of thrombi and inflammation, don't forget to consider secondary disorders such as proximity to an ulcer bed, arthropod bite, or systemic disorders such as calciphylaxis, as I've shown you. Here's a summary of the cases that we've described, kind of covering all the arms here in this diagram, as well as a case of mixed vasculitis and vasculopathy in the case of levamisole. You're not quite off the hook yet. Here's a quick quiz. Question 1. Histologic mimics of warfarin-induced skin necrosis include all of the following except. I'll give you a moment to look at the answers. The correct answer in this case is Henoch-Schönlein purpura. This is not a thrombotic vasculopathy, but an acute vasculitis characterized by perivascular IgA by immunofluorescence. Let's have another question. Question 2. The clinical pathologic features of calciphylaxis can include calcium phosphate balance dysregulation, chronic kidney disease, retiform purpura, vascular calcification, and dermal or subcutaneous thrombosis. Is this statement A, true, or B, false? It is true. Here are some select references from this discussion, and Dr. Madrigal will be providing a link to some of the key articles for you following this talk. I thank you. I think that's all I have for you for cases and questions. I am now open to your questions. In the meantime, I appreciate your joining me, and special thanks to pathCast for providing this international platform. I'm including here the link to the Learn MGH Pathology site, wherein I have provided a teaching set for all of you that includes the cases I discussed today and over 200 others. For your quick review, they are completely de-identified and categorized by content. Lastly, find me on Twitter. I'm at Nazarian MD. Feel free to email me directly at this address for any questions. Thank you.
If anybody posts questions on YouTube or Facebook, I can pass those along to you, and then we can answer through the pathCast YouTube and Facebook pages. So I just, I want to let you know you had viewers even at this odd time zone. I guess I would say it's 2 o'clock here and on the East Coast in the United States, so that would make it past midnight in India, and it's like 9 o'clock in a lot of places in Europe. But you had viewers from Saudi Arabia, Libya, let's see, there are viewers from Albania, Brazil, so quite an audience. And I'm sure other folks will watch the video after, now that it's on, that they can view it on demand. So again, thank you so much for this DERMPATH lecture, and hopefully we'll have you back on pathCast sometime in the future. Thank you so much.
Thank you.